saying, hi, I'm Dr. Drumsky, I'm your friendly neighborhood bone doctor. I'm going to check you and make sure nothing else is going on. If anything I do is painful, let me know. And I'll squeeze his skull, squeeze his midface, squeeze his jaw. Now people always go, I can't clear the C-spine because I don't have a CT. Here's a novel idea. How about we examine it? Because if you put your hands right behind your sternomastoid muscle and push in side to side, that's your C-spine. So if you want to know if it's broke or not, how about we just touch it, shall we? So if I go right at the base of his ears behind his sternomastoid muscle and push in, well, that's 2 and 3 and 4 and 5 and 6 and 7 on the bottom. When I reach in the back, that really knobby one, that's T1, so that means right above it is 7 and 6 and 5 and 4, 3 and 2. 1 is so tightly bound to the base that you can't really feel it. So if he has no pain with A to P or medial to lateral compression of any of those things, and I say, lift your head straight up for me, and he can do that, what do you think his chances are of having a functionally significant C-spine injury? Provided he has a good lateral C-spine that shows no fracture, it's essentially 0. Okay? So I'm going to use my thumbs, push down on his clavicles. I'm going to push up against his body weight on the scapulus. Now if you go to the doctor book, there's all kinds of name tests for the shoulder. Speeds, and Jobs, and Crank, and Jurgensen. And you know what? None of that matters right now. What is this? It's a shoulder. What's it do? Well, it flexes, it extends, it abducts, it externally rotates, and it internally rotates. That's what it does. So what do you think we want to do to it? Yeah, E, all of the above, right? Okay? This is a long bone, a tubular long bone. If I squeeze it circumferentially, I may not really displace it enough to detect a problem. So long bones get a bending moment. This is an elbow. There's a lot of name tests for the elbow. But what does an elbow do? It flexes, it extends, it supinates, and it pronates. What are those? Little tiny long bones, aren't they? So I'm going to bend them. Here's a wrist. What's it do? A little bit of this, a little bit of that, a little bit of this, a little bit of that. These are little tiny tubular long bones. So I'm going to bend each one. Squeeze each finger. Then what am I going to ask? I'm not going to say, do you feel this? Because he'll answer me truthfully. But that's not really the answer I want, is it? What I want to know is, does this feel normal? If he says, I'm not sure, then you scratch his face or something that's unaffected and you say, if this is 100% of normal, what percent is this? Then he can give you a rough number, right? 4, 5, 6, 7, 8, T1. Now what's the poor man's neuro exam for the upper extremity? There's 3 nerves that make it down to the hand, right? The radial nerve. The last thing that the radial nerve makes move is the tip of your thumb. Bend the tip of your thumb up and down for me. Good. Okay. Does this feel normal? That's the superficial sensory branch of the radial nerve. His radial nerve is working. The median nerve comes down here, right? What's the last thing that the median nerve does? It makes your thumb go across your palm. That thing that the chimps wish that they could do, right? And so, what's the last thing it lets you feel? It lets you feel the sensation in the pad of the palm. So, does this feel normal to you? Good. Give me an OK sign with your pinky. Hold that tight. That's a functional median nerve. Last thing the ulnar nerve lets you feel is the side of the finger, side of the small finger. Feel normal to you? Good. Fingers apart. Keep them apart. Don't let me squeeze them together. That first dorsal interosseous, the thing that lets you spread your fingers and cross your fingers, that's the last thing the ulnar nerve does. If those are all working, then by definition everything upstream is working, isn't it? So that's the quick poor man's neurological exam. Relax for me. There's a reflex on the bicep. There's a reflex on the brachioradialis. There's one on the tricep and deltoid tibia. They're harder to get. Okay? Give his chest a good squeeze. Got to lean on that pelvis, right? Full body weight. Front to back, side to side. And then it's a hip. What does it do? Remember I told you there's something special about the hip, right? Hand me my femur over there, would you? The thing about the hip is that the blood supply to the head runs up the back of the neck. And if this guy's got a femoral neck fracture and you displace it, you've just created a bad problem, haven't you? Because prosthetic joints don't do well in young people, do they? So you've got to rule out a femoral neck fracture before you go wagging that hip around. Fortunately, the easy way to do that is something called the log roll test. If you just pivot the femur on the neck without really flexing it and putting the full weight of the leg on it, if there's a crack there, it'll hurt, just like bending a long bone, right? So what you do is you grab them by the knee, not by the leg, because this may be disconnected. Grab them by the femur, unless there's a fracture there, right? Put your finger on the groin crease up front, because pain from the femoral neck radiates anteriorly to the groin crease. And you rotate them and you say, does this give you pain under my fingers? And if they say no, well then it's a hip. It flexes, it extends, it abducts, it internally rotates, it externally rotates. What's this? It's a long bone, so I'm gonna bend it. I've already flexed and extended the knee by virtue of the last thing I did, so here's another set of long bones that I can bend, and then we get down to the ankle. What do ankles do? Well, they dorsiflex and they plantar flex. They also invert a little and evert a little. Little tiny long bones, squeeze each one, check each toe. 2, 3, 4, 5, S1. S1. Now you're looking at me going, God, that crazy old guy shaking his femur at me, this takes forever. There's no way I can do this in combat. Who's going to watch? Ready? Go. Hi, I'm Dr. Dromsky. I'm your friendly neighborhood bone doctor. I'm going to check you and make sure nothing else bad's going on. If anything I do is painful or uncomfortable, you let me know. Lift that head up for me. Is that okay? Yes, sir. Perfect. Okay sign with your pinky. Keep that tight. Good. Does this feel normal to you? Yes. Bend the tip of your thumb up and down. Does this feel normal to you? Good. Spread your fingers apart. Keep them apart. Don't let me squeeze them together. Good. Relax. Does this feel normal to you? Good. Relax your arm at your side for me. Hey, do you get pain under my fingers when I rotate your hip like this? No? That's okay? Good. Does this feel normal? Yes. Good. How about there? How about here? Yes. How about here? Yep. Down there? Yes. Good. Okay. Relax for me. Just let that leg hang. Good. Stop. 47 seconds. So 2 minutes. So that means that in 4 minutes, you can actually do a very detailed, very thorough exam that's very unlikely to miss anything, can't you? It also means that you could write C4 to T1. Motor, intact. Sensation, 100%. Reflexes, 2+, 2+. So in a very short period of time, you can actually be very thorough in both your examination and your documentation, can't you? All right, thank you.
Good question, sir.
Yeah.
What about if they're unconscious and tubed or whatever, and you can't ask them about their hip?
Then I would examine my x-rays very, very closely, and if there was any question, I would forego flexing the region.